Oh
Okay.
my goodness.
I don't know what happened. Technology, you know,
That's all
it
right.
happens. It happens.
It happens.
The last thing that it said, it literally like just stopped it. And so the last thing you were saying that you all don't do, the last thing I heard was that you all don't do open heart surgery, stents, things like that. So you could start from there.
Yeah, some of my colleagues do the interventional cardiology and electrophysiology and all those other, you know, subspecialties. But my group, we focus on prevention and maintenance of chronic illnesses like hypertension, like heart failure, like high cholesterol. And yeah, I love what I do so much, but the one gripe that I have about it is how I get my patients. I get my patients when they've had a heart attack and they have to come follow up with cardiology. I get them, you know, they've had a stroke and they are told to follow up with cardiology. So I absolutely love doing talks like this because prevention is everything.
Yeah, it really is. It really is. So I'm just curious, how did you get into that? Were you a bedside? Did you work on like a CVICU or something like that? Or how did you get into that?
So actually, back when I was an LPN, one of my roles was a cardiovascular tech, and I did stress tests. So I got to meet people when they were doing screening for diabetic disease. Okay. So I just continued on with school, and as an RN, I worked on a progressive and critical care unit where patients be hospitalized in the inpatient setting. So the heart failure patients, the cardiovascular or coronary artery disease patients, peripheral artery disease patients, and a lot of diabetes.
Okay.
Then I got my MP and just went to practice with my friends back at cardiology.
Okay. Yeah. So many people probably don't know, I know you know, but we can tell people who are viewing in, this is Heart Awareness Month, in addition to Black History Month. So I thought it was only right to talk about the two because that is a high risk group. Okay. You know, you have African Americans, we're a high risk group for diabetes, heart disease, kidney disease. And so I felt like you were the perfect person to come on and just kind of enlighten us about some things, especially because this is what you see. And so I guess my first question to you is, what is like the incidence of like people that you see that have both? They have diabetes and they have cardiovascular disease as well. Is that like pretty much all of your patients or half, or what would you say?
Yeah. It is a significant amount of our patients. There's about 29 million people in the US with diabetes right now. There's about 6 million with heart failure. So you probably see a lot of diabetics who don't have cardiac disease, but by the time they get to that point, they often come with both issues. Now, one thing that I've noticed and I think is really interesting is our very elderly patients, a lot of them with heart disease do not have diabetes. But a lot of the younger people, a lot of the younger ones, and when I say young, listen, in cardiology, 70 is young. But a lot of our younger people are coming in with diabetes. And I think that speaks to the incidence and the increase in type 2 diabetes nationally. Okay.
I don't know what just happened there. We'll turn that right back around. Why do you think that, that your younger patients are having diabetes and not the older ones?
Yes. There are so many different ideas that go into that. The simplest way to put it is that we're heavier than older generations. We just carry more weight. And weight is just one of those really highly emotional, really touchy subjects. We're really into body positivity as a culture. We love our thickness, but the truth of the matter is sometimes there's risk that comes with that. We definitely see people who are average body weights or ideal body weights with high cholesterol, a type that is familial or genetic. But oftentimes when we see this combination of metabolic syndrome, which is hypertension, diabetes, obesity, and insulin resistance, it is heavier patients. So I think that the way we eat, the way we live our lives, everything is really instant. We don't have time to exercise. We don't have time to cook. We don't have time to cook. And so when you're not cooking, what are you eating?
Yeah.
Out of a box, a bag, a can, the freezer, fast food. And if it can live on a shelf for a week, then it's full of preservatives and consequently full of sodium. So yeah.
I probably a couple of weeks ago, I did a live with endocrinologist Dr. AADE7, and she said something that really blew my mind, was that this is the first time ever that the younger generation is probably going to like not outlive the older generation because of our lifestyle. Like we're actually, the older generation is actually healthier than we are. And
100%.
Yeah, like it's never been like that. Normally, as you age, you pile on more chronic illnesses, but that's not the case. Now it's the younger generation is having a lot of chronic illnesses, and earlier in life than what we're used to. It's not a grandma and grandpa type of disease anymore, you know? And so I wanted to also ask you, at your practice, what are some things that you all work with your patients to do, and some things that in a primary setting, not some more specialty like you, where we're kind of seeing everything. What are some things that we, as a primary care providers, what are some things we can start to implement?
Yeah, that's a really great question, and it's an easy answer for me, but I think that it's something that is often overlooked in the primary care setting. The threshold for a diagnosis of hypertension used to be greater than 140 for a top number, over 90 for a bottom number. That went away with the new guidelines that came out at the end of 2017. That threshold is now 130 over 80. And that might not seem like a lot. It's just 10 points either way. But it literally made almost half of American adults diabetic. Hypertensive, not diabetic. Just by lowering the bar 10 points, we had all this influx of people who now need to have their blood pressure tightly managed. But think about it. This happened when primary care providers were out and practicing. And how long does it take new guidelines to really catch on? You know, it takes time. So I think that's one of the major things that we do is really tight blood pressure control. Another thing that I do in my practice is I refer to two specialties very often, more often than not, and that is sleep medicine, because sleep apnea, obstructive sleep apnea, huge implications for heart disease, and endocrinology. I always order A1Cs on patients who have a new cardiac event, because there's not being diabetic and there's not knowing that you're diabetic. As you well know. So the ABCs for us for diabetic heart disease are the A1C, blood pressure, and cholesterol. And those are the three things we really work on in our practice.
You sent me the that podcast link, and for those who are interested in what I'm talking about, I'll link it, and I'm going to record this live, so it's going to go up on my YouTube channel, and so I will link that podcast episode. But it was about 30 minutes, real good, and I had actually wrote that down. on the ABCs because one of the things that I feel, I was kind of just reflecting today because the endocrinologist said something really, really interesting. He was like, you know, gone are the days where we just focus on the glucose, you know, like just focusing on lowering the glucose, we were not getting good results. You really have to look at the patient in their totality. And they brought up the ABCs of diabetes and in relation to heart disease, which is the A1C, BP, and the cholesterol, and really moving the mindset of like there is overlap. And it's so funny because I remember being like a brand new nurse practitioner. And I used to tell people, you know, diabetes, cholesterol, high cholesterol, and high blood pressure, they're not brothers and sisters, but they're cousins. They like to run together, you know? So if you have one, you may get another, or there's a good chance you're going to find another one. And so if you manage it all and look at the patient as a whole, then we can really remedy all of this, really.
Right. Absolutely. And I think that knowledge is so key.
Yeah.
And one of the things that kind of pains me about the way we practice is we have all these specialties. You know, who can afford to go to 3 different types of practices and have all of them talking to each other, knowing the right hand knowing what the left hand is doing? I think we make it really complicated. And one of the things that I love that Charmaine Jones said, she's a dietitian. In fact, we call the podcast episode "We Make It Hard," because I had all these questions for her about eating and food and what should I be recommending and what's the best diet and this and this. And it was just so sweet to watch her go, oh my goodness, you know, smaller portions, fresher food, eating the rainbow. So while we really focus on these numbers, and we're really just techie generation, we like our gadgets, we like our numbers, we like our information, but it's what you do that really is going to lower the risk. It's what we do day in and day out. Are we moving? Are we eating fresh food? We really focus on that a lot in cardiology, a lot.
That's really good. One of the things that I wanted to touch on too, as providers, you know, you have your modifiable risk and you have your non-modifiable risk, you know, and, you know, since we are talking about, you know, we're talking about all diabetics, but we're also going to focus on the African-American diabetic with heart disease. And there's a lot of things that's out of our power as far as our race, our gender, you know, there's nothing we can do about that. But the modifiable risk, we really need to double down on that. Even today, I had a conversation with a lady, an elderly lady, and she still had the mindset of, well, I need to increase my water, so I'm probably going to drink my 8 glasses a day. And I was like, you know, I always have to tell people, think about that. One size doesn't fit all. Like, really, if you think about it, everyone should drink the same amount of water. When you have tall people, short people, more, you know, people who have more muscle composition, some people leaner, you know, everybody would be able to drink the same amount of water. Like when you think about it like that, it doesn't make sense, you know? And so I think, I'm really seeing the tide turning where we're having to look at take a holistic approach, and really help our patients to connect the dots as well. So another question that I had for you as well, what are some, you know, we hear all these diets that are out here. I mean, there's a diet that comes out all the time. Right now, of course, a lot of people are doing vegan, plant-based, which I don't think anything is wrong with any diet. You know what I'm saying? There are some that ain't so good, but you know, plant-based, that's good. I do think that's good. But for you as a person in specialty, what are some of the things that you help your patient, the person who maybe can't afford to go to Sprouts, the patient who can't probably go to a Whole Foods? What are some practical things that you tell your patients when it comes to changing their diet?
Yeah. So we really like the Mediterranean diet in cardiology. We like good fats, you know, from nuts, from avocados, from olive oil, fishes, fatty fishes. We love the Mediterranean diet. Lots of vegetables. We'll get people who say, well, I don't like any of that. And I think that's one of the things that we really have to try to look at when we're looking at the whole person. We can print off this diet and give it to people, but I'm lactose intolerant. If you give me a diet full of dairy, I can't follow that. I can't do it. I don't like it. It makes me feel terrible. And so what I have patients do is change nothing for a month. Just observe the way you eat for a month. And then come back and tell me about it. I also do a 24-hour diet recall. And a lot of times when we go 24 hours back and look at everything a person ate, there wasn't a vegetable in sight. Now, the thing I love about the 24-hour diet recall is it really clues you in as a provider of where a person's at. We can always come to patients with where we're at and what we want, but if we don't start with where they're at, I had a guy who ate an Egg McMuffin every morning. That was his breakfast, was an Egg McMuffin. His lunch was something else, freezer and processed. You know, you start to go, oh, this person doesn't cook. And so then you have to start thinking about, well, how can we make their diet more nutrient dense, more anti-inflammatory, with what they have to work with. So I like to do it that way. And then I also like to have people come back for follow-up. I'll tell you a story. I had a guy who his cholesterol numbers were off the hook. And I was like, you know, he was young, I think 40. And I really didn't want to just put him on a statin, but you know, he was pre-diabetic. His cholesterol numbers were high. He was hypertensive. He had some extra weight he was carrying. And so I said to him, I said, listen, I know you didn't come in the first visit and want to be put on a medication. So here's what we're going to do. You watch what you eat for a month. Don't change anything. Just do what you do. And then come back and talk about it. He came back and he said, I'm horrified. I said, well, what do you mean? He said, I eat 16 bacon cheeseburgers. And the only reason it wasn't 20 is because Friday was Philly cheesesteak day. I didn't have to do much of anything. Just him being mindful of what he was actually putting in his body was enough motivation for him to turn that around. Yeah. So I think a lot of what you were talking about earlier, our generation not living as long as those, you know, before us, we have so much stress and so much pressure and so much go, 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 that we lack mindfulness. So if we just slow down enough just to go, okay, let me just pay attention to what I'm eating, a lot of the work gets done right there. Yeah. Yeah.
So, anything else you want to tell the people? Any other takeaways that you would like to give to, because I have a lot of people that are nursing students, aspiring nurse practitioners, some people who are just primary care providers, you know, and I think, you know, it's really good. I wanted to bring on people like you, people like Dr. Thingadu, who are specialists, and kind of see on the back end, you know, not to say that we're not doing our jobs, but, you know, what are some things that, like, you know, if we could have better collaboration, what are some things that I would like to see, or some things that, the one thing that if you didn't have any more time, this is what I would want you to do?
No more time. That's the truth right there.
Because that's really, I think that's part of the problem, is that we want to do all the things. We do. But, you know, our healthcare, I mean, we can go on and on about how our healthcare is broken. It's broken on both ends. It's broken for the patient. It's broken for the provider, because you want to do all the things, but it's like, you can't really take the time to educate the way that you want. So that's why I always want to ask the question, what's the one thing as the cardiologist MP, you know, what is something that you would double down? I'll give you an example why you think. Dr. Thingadu was just saying that take advantage of that pre-diabetic patient, or that patient that was like 6.5 to 7.5 before they get too far gone, because we can actually turn them.
Right. I think the biggest thing is empowering the patient. We all know that if we don't have their buy-in, nothing gets done. We can talk till we're blue in the face. Find the family member. Find that when you describe the symptoms of advanced diabetes, asking the question, you know, is there anyone in your family who has? That puts a picture in their mind that is also emotional, an emotionally connection to something. Because I can say heart failure, heart failure, heart failure. But when I say can't lay flat in a bed, then they think of grandma or daddy who sat in the recliner because they couldn't lay flat, and they go, oh, that's heart failure. And then we run it back and we say, and this is how we can avoid, you know, you going down that same trajectory. We get our habits from our parents. So whether something is genetic isn't always key. And there's a lot of DNA tests and all this kind of stuff out right now where people can say, oh, I don't have that gene, I don't have to worry about it. It's habits. The habits are really what put us at risk. And so that's the big takeaway for me. You know, the big thing that I encourage people to do with, and remembering that these are just people. They didn't go to all these years of school. They're just out here trying to make it like the rest of us. So connecting on that personal level of, this is what your future is going to be if you remain on this trajectory. What would you have wanted differently for your grandmother? What would you have wanted different for your father, for your auntie? Are you worth doing the work so that they can have that through you? And I don't even know if that makes sense. But
yeah, it does. It really does. I believe that oftentimes, especially when it comes to like diabetes, or it comes to heart attacks, strokes and stuff, I think people have a picture in their mind what that is. They do think about their grandmother who had an amputated foot or leg or something, and think, well, I'm not and that's why I was saying earlier, connecting the dots for people to actually explain to them, like what you just did. Like when you say heart failure, that can scare somebody. Oh, I don't have that. No, actually, you may do. You may have it. You may be at risk for it. And this is how it can look. You know, I have seen many people's like printouts from hospitals where that diagnosis was congestive heart failure, but they have no idea that they were diagnosed with that. And they're on the medications for heart failure. They're on the diuretics and all this stuff. But, you know, they don't know. And so I think, you know, part of empowering is taking it a step further to actually let them know, like, this is what you're dealing with. And there is
That's okay.
So where can people find you?
Oh my goodness.
On the internet.
Yes, on the internet. Well, @D the MP is my Instagram, it's my Facebook, it's my Twitter. I do a weekly podcast called The Purple Stethoscope, where really those discussions are for non-medical people. Love what you do for providers with the, you know, diabetic education that you provide. But the difference from what I'm doing is really for the lay person, truly to have that access and just hear about things that they may not be able to hear about otherwise. So the Purple Stethoscope is on Spotify and iTunes and YouTube. And then the interwebs @D the MP.
Okay, and I will also leave all of your information as well. And I think this is great because if, you know, for the busy practitioner, provider, having having a resource like your podcast, so their patient can listen to it while they're in the car. They can listen to it when they're cooking, or doing whatever, cleaning, and then that can be, we're all working together for a common goal.
That's it. And the goal is not to become Black history.
Yeah.
Not too soon.
We don't want to go history.
Not prematurely.
You're not history yet.
That's right. I did put up some information on my Instagram. The post with both of our pictures. There's some things that folks can scroll through, just information. But thank you so much for having me, Kim. It's good to see you.
It's good to see you too. And so, anywho, guys, this will be up for 24 hours. And then once it goes down, I'll get it all to, packaged up nicely, and I'll put it up on my YouTube channel.
Thank you for doing that.
Oh, yes. And you have a great night, okay?
You too, sis. Bye.
Bye.